This portion of CardioSource Video News is supported by the makers of Xarelto.
Welcome to ACC.12. I'm Dr. Randy Martin with CardioSource Video News. And you know, one of the interesting problems we all face is this concept of how do you triage patients with acute coronary syndromes in the emergency room. And I'm pleased to be joined now by Dr. Udo Hoffman, who's from Mass General Hospital.
Thank
you.
you.
And Udo, you all have done a fascinating study. Tell me a little bit about the Romicat Ii.
The Romicat Ii trial is a randomized control, strategy control trial that really compares two strategies to manage and triage patients in the ED. One strategy is you get a CT first the moment you're in the hospital, and the second one is you get your standard of care that can include stress testing, functional testing, or just observation.
So it's a randomized. How many people did you all enroll?
1,000 patients in 9 centers in the US.
So that's fabulous. So big numbers, powered well. What did you find?
So we found that in this trial, patients that were in the CT arm were discharged much faster than patients in the standard of care arm, while it was safe to discharge them. Meaning, despite that they were discharged faster, they didn't have any acute coronary syndromes later on. And the numbers are that 50%, it took about 8 hours to discharge 50% of the patients in the CT arm. It took 26.8 hours to discharge 50% of patients in the standard of care arm. And another more,
So that's dramatic. That's a 16-hour or thereabouts differential.
Right. It's a pretty dramatic shift that we've seen. I would summarize that the shift that we've seen is you have a tool early on, you introduce a diagnostic tool early on that tells you who is sick and who is healthy. And it really stratifies patients very strongly at the beginning. So the majority of patients do not have a coronary syndrome and can be sent home. And then you have about 30% of patients where you detect disease with CT.
Right.
And we also saw that those undergo more stringent testing than in the standard of arm. So in a way, the resources are kind of shifted to the patients that are sick. In my point of view, that is a really good thing.
That's great. You didn't send anybody home based on the CTA.
Oh yes, they were all.
No, I meant that had an acute coronary syndrome.
Absolutely.
So you were 100% accurate. But so the concept. So you saved time, obviously, and resources there. What was the cost differential of the two arms?
So the cost was actually the same in the two arms when you look at the overall cost. And this is driven by the high cost, for example, of invasive angiographies,
Sure,
which were more frequently done. And also interventions were more frequently done in the CT arm. So it's a 32 versus 21 PCI or bypass. And that really drives that, despite that the cost for the ED evaluation was much lower in the CT arm, that overall the costs were the same.
Okay, so very important data. And where do you think, sort of what's the take-home message in this? I mean, is this going to transform the way we look at, or potentially transform patients in the emergency room?
I think it provides a solid comparison that CT is a valid alternative that does not cost more and is as safe as standard of care evaluation, but that you can actually discharge many patients earlier. And what we have not been able to assess in the study so far is probably the larger benefits for the ED, because as you can envision, the patients are now cleared, so the ED can take care of other patients. And also the patients are being sent home, they have a better quality of life, obviously. And there are also other studies that suggest that downstream CT, the information that you have, the powerful information that you don't have any CAD, will save potentially testing down the road.
A fascinating study, and congratulations on not only doing it, but doing it very, very well. And certainly it may impact our practice a lot. Thanks very much, and thank you for joining us. Be sure to stay tuned, because we'll have more from ACC12.